Thank you for joining us today. My name is Kate Gerard. I'm the director of the WIC program here in Montana, located in Helena, Department of Public Health and Human Services. I'll be joined today by my colleagues who have been working on a project with us called the Nutrition Access Project, or NAP. And we are working with the Montana chapter of the American Academy of Pediatrics, as well as the Montana Food Bank Network, and Yarrow Public Health Consulting on this project primarily, as well as many other partners we'll discuss along the way. And we'll be laying out the project thus far and where we're headed with it. A little bit about the WIC program, just to ground the presentation. WIC stands for Special Supplemental Nutrition Program for Women, Infants, and Children. We serve women from the time they find out they're pregnant all the way through the postpartum period for 6 or 12 months, depending on breastfeeding status. And then infants and children can stay on until they're 5 years old. We do certify at least annually for children each year. We provide food such as milk, cheese, eggs, peanut butter, fruits and vegetables, eggs, whole grains, cereal. For breastfeeding moms, they get a lot more food than anyone else, but they also have the opportunity to get a free breast pump and breastfeeding support. And for infants who are not exclusively breastfed, we also do have formula available. We also provide nutrition and breastfeeding education and support, and make referrals to other programs that they may benefit from. Unlike some other programs, WIC is very targeted to that perinatal period and to early childhood. The primary focus of this grant is to address food security in children in Montana in a couple of ways. One, by educating providers about food security in general, increasing their ability to refer and screen for food insecurity, as well as improving the partnerships amongst the providers and those in the food security space across the state. The framework for the project is collective impact, which I'll talk about a little bit more. In addition to the partners that I've already mentioned, some other partners include home visiting, Head Start, providers who work with our perinatal and pediatric population, the Food Security Council, and the Montana Food Bank Network. So as mentioned, our partners and stakeholders are listed here. Again, this is a collective impact model, which means we are focused on working throughout the early childhood and nutrition assistance systems to move the needle on this issue of food insecurity. So as you can see here, all the folks mentioned, parent partners, the WIC local and state staff, Food Security Council, Montana Food Bank, No Kid Hungry, as well as our healthcare provider partners at the local level and the national level, and other programs that we work with frequently are all part of the landscape. They all touch families that we touch, and they all care about food security. So the collective impact model that we're implementing here is really about that. It's really much bigger than the project itself. It's about finding a common thread across the system where we can all address a particular issue in some meaningful way and come together and continue to share that information. Another great model of collective impact is the Montana Partnership to End Childhood Hunger, which has been operating under that model for several years. And it's a really beautiful network of people they brought together, and many folks in the space benefit from that. So collective model is not specific to food security. Certainly it is a model that can be utilized in many, many different areas, and other public health programs may operate like this and not even realize it, but could really benefit from formalizing this model. For instance, immunizations. Let's say immunizations really wanted to ensure that all kiddos are up to date by 3 years old. It's very clear who their partners really should be, I think. Local providers, local health departments, maybe home visiting, WIC, even Medicaid. You know, there are all kinds of programs that maybe touch the population that they want to, again, move the needle on getting immunizations up to date. So this kind of model would be perfect for programs like that. So the elements of this project essentially are to build an evaluation plan. That was the first thing we did as a part of the grant. We wanted to make sure that we were developing metrics and following, quality improvement cycle that could be evaluated well and then shared eventually. Establishing the local sites for WIC integration into pediatric or other types of clinics to improve WIC enrollment of eligible families and improve provider program relationships. Actually do the quality improvement project locally or the pilot. Screening and referring would happen in the doctor's office primarily, and that would happen at well visits for children under 5. However, Head Start and other programs may also have some data to contribute as we partner with them along the way. And then, of course, ideally, we would expand the model based on the results. So a little more specifically, the 3 models that we have, again, are in Bozeman, Billings, and Missoula. In Bozeman, the mother-baby unit is where we are piloting. And basically, the Bozeman WIC staff go to the hospital a few times a week. They meet all the new moms and babies. The hospital is screening all moms and families for food insecurity, as well as participation in programs like WIC and SNAP. And therefore, when the WIC staff go into the room, they already know whether they're participating in those programs and whether they screen positive for food insecurity. When they meet the parents, they are providing information about WIC as well as other programs like home visiting and maybe giving a nice little gift for the new baby and either scheduling them or enrolling them or just leaving them with information. In Billings and Missoula, again, the original intent was to integrate the WIC clinic into the pediatric setting, but due to a number of barriers, we switched gears, and now we are focusing on educating providers about food insecurity, having them identify families who would be good to refer to WIC or other programs such as SNAP. And then we have developed some tools to move towards a warm handoff between the provider and WIC rather than just a simple referral and they leave and they don't know what happens after that.
Can you introduce yourself and share where you work and your role?
Yes, thank you. My name is Debbie Hirschberg, and my pronouns are she, her, hers. And I work for the Missoula WIC program, and I have been here for 15 years. And I am a CPA and also am a nutrition coordinator, so kind of coordinate the clinic and keep things going and do outreach and retail stuff and everything from breastfeeding consults to things like this, outreach and retention. And my role with the Nutrition Access Project is kind of guiding this and kind of helping it to implement it and see how it can work for our community here in Missoula.
We've learned that each site has a different model in integrating WIC. Can you describe the model at your site?
We had thought originally and had hoped for that on-site model that was kind of ideally would be serve all of us. And that was not feasible for us here in Missoula for a couple of reasons, both here in our Missoula clinic for capacity. We're just short-staffed and not feeling like we have the stretch to go out to the office. And the other reason is for space. Our Providence Pediatric, the provider office, they don't necessarily have the physical space for us there. And so the logistics hopefully will come down the road. And so we modified ours to become a referral model. And that is what we have been implementing and have started working, building that referral network from the Providence Pediatrics to the Missoula WIC agency. And they are doing some screening questions, some food security screening questions at all the well child checks if the need is identified, and then referring to the WIC program if that person would like that referral and connect with the WIC program.
Are there any points of interest so far in the experience that have stood out to you from the initial plan into what you're doing now? And if you could describe any progress you've made so far?
I think one thing that we had envisioned first off when we decided to do the referral thing, I think both Dr. Rogers and I had both thought, this is great. We're going to get all of these new participants on the WIC program. And we pretty quickly found that that wasn't necessarily the case. And a lot of times it was people that had been participating in the program at another point, whether it was a year ago or 3 years ago. or 5 months ago. And most of those referrals are people that are coming back on the program. And that was pretty surprising to us.
Share your experiences collaborating with Dr. Rogers.
Dr. Rogers has been a pleasure to work with since day one. I've really appreciated that. I feel like as a local WIC agency, it's oftentimes hard to get the ear of a medical provider. And so I feel really grateful that Dr. Rogers has the interest of the WIC program and food security in the clients that we both serve. And that has, I'm hopeful that her passion and the knowledge that she has gleaned about food security and the WIC program particularly, she's able to carry that forward even long after this pilot is well implemented and able to share that with her colleagues, other providers within our community, not only within her practice, but other pediatricians throughout the state, sharing the value of the WIC program and all of the benefits that it has for our communities.
How about for your work, from your end, has like engaging with Dr. Rogers given you thoughts on your role at all?
It gives me hope that there can be more collaboration and we can have strong, meaningful relationships with medical providers. Clients trust their doctors. They trust WIC as well, but typically they first trust their doctors. And I feel like that it's helped us by having our Dr. Rogers, who's an asset to this community, have more knowledge about the WIC program and being able to share that information back with WIC clients and kind of full circle, bring them back to WIC in that trusting network.
Share your experiences collaborating with a parent partner.
The parent partner is a key piece to, I think, almost any pilot project, but particularly this one. It's so easy to develop processes and policies from the clinic standpoint and from people that are working the program. But if it's not applicable to the actual clients that are utilizing the program, we've entirely missed the point. And I feel like that's where the parent partners, all three of the parent partners, obviously I could speak most specifically for mine, but they all have input and they bring up points that we wouldn't think about. We might have thought about when we were young, when I was younger, I might have thought about that a little bit more. And when I was a WIC mother as well, but I've got a teenager and I'm pretty removed from that. And so I really appreciate the valuable input that they have and bringing the scope back down for us to be a little bit more practical and useful for participants, because that's the point of this, is to be useful for participants and approachable for them.
Are there specific points that come to mind that parent partners brought up that you're like, it was like an aha moment?
I don't know if specifically it was. I think maybe one thing would be just the paperwork, having flyers available in the office to give to clients isn't always useful when you have a couple kids that you're holding with both hands and trying to get out the door. And that piece of paper probably isn't going to be that useful. And so having posters available when you're waiting in a clinic room for the physician or in a bathroom or something like that is a little bit more maybe realistic. They can quickly snap a picture of it with their phone and then, catch that later at another time when they're not as busy. I think another important point that maybe isn't exactly what you're heading for here with this question, but is time. Our parents are busy. And so when we schedule meetings at 10 o'clock on Wednesdays, they're likely at work when so keeping that in mind, most of our parents are working. They are, either single parents or multiple parents, but they both have jobs. They have busy lives. Some of them are going to school. And so when we try to schedule meetings to include them in these conversations, I think that is something that we should have considered a little bit more, is making sure everybody is at the table.
That's an excellent answer. And really, thank you for giving the description of what these participants are doing, because there's generally a notion where that's not the case. So really, thank you for hitting that point. You've kind of shared this, but are there any other things you'd like to share that you've learned from this experience?
I think one thing that this has highlighted for me and reminded me is how valuable and passionate all of the stakeholders of WIC are. So everything from No Hit Hungry to the Montana American Academy of Pediatrics. everybody that's involved in this, everyone cares. And I think that that is always highlighted and such an important thing to remember. I think also that we've learned if the first idea and the first draft doesn't fit, like being on site and having this perfect magical handoff, warm handoff doesn't work, there's other options, and we can go back to the drawing board and see what works for each clinic, because as we all know, each WIC clinic site operates really different. So having as many ideas in there and flexibilities, I think, is really important. I think the last thing that I really learned from this experience is time. And I think most of us would like more time, but I really think that having time, giving time, and not forcing or not rushing things is really important to be successful and to decrease, stress, which allows us to be creative thinkers and having some time to think and plan, as opposed to boots on the ground. This is what we're doing. Okay, that didn't work. Let's go again. Having a little slowing down a little bit, I feel like would have helped me, but that's kind of something I'm always working on, I feel like, professionally and personally. We want more families to be participating in WIC because we want our future generation to benefit from the WIC program, both nourishment and education. Going back to what I had said just a few moments ago about our clients being busy, our clients going to school full time, having one or multiple children, working jobs and living, making WIC as easy as possible by collaborating with providers, whether it's on-site eventually or just providing the heights and weights and hemoglobins that are required for the WIC program. That will, I think, decrease barriers to WIC participants, which is our goal. And that's my hope with this project moving forward. And I really am just very thankful that Missoula WIC was invited to participate in this pilot project. And I appreciate the time and guidance that has been provided by all the people contributing to this. And I do hope that someday we can do that integrated care with WIC at the pediatrics office. And that might take an entire clinic model shift to where we're out in the community at various locations, more than pediatricians' offices. And that we'll see where that all goes. But I think that is an important thing to not lose sight of and see how we can make it work in the future. Thank you again for the opportunity to share this information and the collaboration of all of the stakeholders that are going to benefit our Montana community. It's an honor to be a part of this project, and I feel like I have learned so much from not only from all of you, but from Dr. Rogers and our participants as well, and what's working for them and what isn't working for them. So thank you for your time. I appreciate it.
My name's Lori Littledog, and I have been using WIC for both of my children. I have a 14-year-old and a 7-month-old. We've just, we're now parent participants for the pilot project that we're working on this term, and there's a lot of insight that I've gained over the past 14 years to share.
Can you share your interest in joining this project?
I've worked with WIC in both the inner cities in a different state and in the more rural communities here in Montana. So when the opportunity came up to talk about what it's like to be a parent in the WIC program, I thought that had a really vast array of benefiting from the WIC program. So I wanted to use that experience to share with the people in charge.
Why do you see this collaboration between WIC and pediatricians important in increasing food security?
It's super important because just as a parent, it's important to know that you're talking to a healthcare provider that's a safe person. So when it comes to nutrition and, just kids getting access to nutritious food, it seems like the pediatrician needs to be a part of a team. And so if someone's comfortable talking with their pediatrician about the kids' health care, they should also be able to expand that to access to nutrition.
What do you see your vision for this project?
WIC has been around for a really, really long time, since like the 70s. And when I'm talking with other moms, whether it be at the library or at the park, a lot of people I'm finding don't realize that they qualify and are eligible to get WIC benefits. A lot of people assume that it's like EBT or SNAP, that it has a pretty strict income requirement, but it's not the case. WIC has a huge difference when it comes to eligibility. And I think a lot more people would partake in the program once they realize that it's not really about income. It's about getting kids their first 5 years access to nutrition. So there's a lot of benefits when it comes to utilizing the different programs within WIC. Like right now we have the Farmers Market program. You can use the WIC dollars to go and get fresh fruits that I will be turning into pureed baby food for my daughter.
Awesome. Can you elaborate on the impacts you see this type of project having on rural families?
Oh my goodness. Yeah, there's so much that can be done. Is a lot of rural areas are food deserts, right? So you can't, when you go to the store, you're not finding good prices on produce. And sometimes the produce isn't the greatest quality. So what WIC has the opportunity to do here is to really look at the local level produce makers like farmers and different kinds of resources to get access to fresh fruits and vegetables. So what I'd like to see more of is WIC really utilizing their physical locations, access to the local farmers and the growers that are picking the carrots, and like letting kids really see where their food comes from, especially like in the younger ages, so that they can realize that this should be part of everyday living and it should be accessible to everybody. First 5 years of life. And when it comes to the pediatricians and the doctors working with the families to stress the importance of having a colorful food plate, and even from baby food all the way up into when they're toddlers and in kindergarten, having that farm to market idea. It shouldn't be just an idea and a thing that we do only part of the year. It needs to be a year-round thing. So the more that medical providers and pediatricians and just adults that are in the formative years, like in the daily lives of kids, really demonstrating that having access to these type of foods is the natural way to go. It should be available to everybody, especially the people that are in the rural and tribal communities. I think that, that living by example and just having it in the office, even, if you have doctors that they have like little things of carrots and things that kids, instead of just offering the lollipop, having that fresh provided thing as a door opener for people to start talking about the WIC program. It's those little things that count. Even in the doctor's office, we were having a discussion earlier today about how a lot of doctor's offices have those television screens that are just kind of showing the weather and different things that are exciting for kids to see. But if they're seeing like a little trip to the farm, and then it's an opener to talk about what WIC can provide the family that wouldn't necessarily be thinking to eat in that way.
Can you elaborate on how healthcare can be involved in food security of patients and their children?
When I go to the pediatrician's office, like one of the things we always do is we do a height and weight check on the baby. And in her case, she's a little bit on the thinner end of the spectrum. With the provider, talking about nutrition and not just saying we need to gain weight, but gain the right kind of weight and develop the healthier habits for eating. I think that for us has really made a difference. We're just a little bit more aware of what we're doing and more intentional when we go to the grocery stores. When it comes to pediatricians talking with families, I think that warm, inviting conversation, talking about using the health and the weight of the child is a good way to start the conversation about, are they getting enough to eat? Are they getting enough of the right foods to eat? And perhaps the child's a little over what they should be. And it's such a delicate balance of approaching nutrition in a way that's going to show that, okay, our family does tend to buy foods that are not the healthiest because there's a common belief that it's too expensive to eat healthy, right? So I think that striking that balance between what it is when it comes to nutrition, being able to access that and being able to talk about, we have been eating more chicken nuggets or whatever it is because it's too expensive. And then that can kind of help I guess, usher in the conversation of, well, if it wasn't as expensive, or if we had a way to offset some of the price to the fresh fruits and vegetables that kids should be eating rather than, the French fry potato thing, choices, then I think that that can help a parent feel more confident and comfortable talking with a provider. And we need parents to understand that WIC is there to help. WIC is there to, to give access and to put fresh food in their bellies, right? So it's not about trying to tattle, and use information that is given in that conversation in a way that could potentially impact in a negative way, but just keep it all positive. And being aware that some families, especially those that are in a truly deficit, living situation when it comes to nutrition, that it's not a conversation that could go in a bad direction. I think that that's, in my opinion, probably the most sensitive subject.
Thank you. Share why it's important for participants of these programs to be at the table when discussing improvement of aspects of this project, like referrals and retention.
When it comes to parents being able to participate in the SHAPE and methods that WIC uses to grow the overall participant base, I think that what's been tried and true in the past is just different now. Like before, it would be a little kind of like the have and the have-nots when it comes to nutrition and being able to give young kids access and to have that voice. Now it's not just low-income people that benefit from programs like WIC or the lowest of income. It's, teachers, it's, military families, it's, the kids of firefighters. It's not, because we're dealing with this weird financial situation in the United States that those methods and like screening is not as obvious as it used to be. So that conversation piece, when we have parents that are able to comfortably talk about what the needs are, that way we're not just plugging and playing what the government wants to dictate the needs are, but just kind of like the everyday lived experience of families. I think it could help. Like, one of the things that I saw that was really helpful for us is that that WIC has an app for the phone, and that they have baby food recipes that you can make now. That was not available 14 years ago. And I would assume that somewhere, in some focus group, people wanted to have tangible, quick ways to make your own baby food instead of just buying, Gerber or whatever, Earth's Best or whatever it is. Because, there's always something that's happened. There's recalls on formulas, recalls on the arsenic in baby food, and giving parents a voice and a solution, or I guess an avenue to come up with solutions or alternatives to getting kids nutrition. I think it's creative and a lot more progressive than the methodology used to be.
Shayna, can you tell us what interested you in this specific project?
I work with a lot of families who are experiencing food insecurity, and having those experiences with my patients and their families has really led to a personal connection for me with this issue. And I recognize that we can be doing better as a medical community and helping families in this aspect. And I want to be part of the solution. I think I better understand now how incredibly stressful this can be for families, both children and for their parents. And I think the way that we as healthcare providers are communicating with families and addressing food insecurity is really important. And if we're better able to be screening for food insecurity and more effectively communicating with families, I think we'll be able to really help a lot of people. This project has been really helpful in a whole variety of ways, and I'm hopeful that we can use this project and share what we've learned with other providers across the state. In prior times, we would give people contact information for the local WIC clinic, but families weren't always connecting. And so the goal was, how do we make this as easy as possible for our families to connect with the local WIC offices? So right now, we're hoping that by sending the referral directly, we're more successfully connecting people with the local WIC offices. And then at the end of the month, our pilot sites are following up with the local WIC clinics to see who was and wasn't scheduled for visits. So we're trying to approach the referral process from a closed loop perspective, where we're following up on the referrals and trying to be sure that people are getting connected with services.
Can you share what you've learned about food insecurity, specifically childhood food insecurity, while you've been working on this project?
I've learned so much through the process of working through this project. I've learned a lot about how food insecurity presents in kids, seeing how it can affect growth and development and behavior and kids' performance in school. It's been really informative from that perspective. I think even bigger than that, though, I've learned a lot about the patient and family experience with experiencing food insecurity, and also with some of the challenges in connecting with resources. And I think by better hearing that perspective and identifying barriers, we're able to be working through those barriers and making it easier for people to connect.
Great answer. Can you elaborate on how food insecurity shows up in your patients, maybe more related to chronic health issues?
Food insecurity can present in a variety of ways in kids. Oftentimes we think of kids experiencing food insecurity as being undernourished, but a lot of times they're more likely to be overweight or obese. And that happens because these families don't have adequate access to healthy foods like fruits and vegetables. And they're more likely, as an effort to save money, to purchase high calorie and more processed foods, which can cause kids to be overweight or obese. As an extension of that, we also see more chronic disease in kids with food insecurity, such as type 2 diabetes and poorly controlled asthma. We also know that when these kids get sick, they take longer to recover. They're more likely to require care in the emergency department, and they're more likely to require hospitalizations. So there are some really significant medical consequences of food insecurity.
So I'm quoting you from a presentation you did, and I thought what you said was so profound, and people don't really understand this, but you talked about food insecurity being fluid and episodic. Can you talk about that?
Food insecurity can absolutely be fluid for a lot of our families. And I think that's one reason why it's really important for kids to have a medical home and for us to be seeing kids, as pediatricians. Food insecurity can really change or evolve for families over time. Business or work may be good one month and a family is doing great. But the next month, families may be struggling and they may need some support. And so I think it's important for us as pediatricians and healthcare providers to be screening patients when they're in the office for food insecurity or for other struggles with social determinants of health. Because just as a family, was doing well last month when they were in the office, it doesn't mean that that's still necessarily the case.
Excellent. Can you talk more, or just use the term again? You talked about establishing a medical home that supports the whole family unit. That messaging will really resonate with many different populations. So
being a pediatrician is a really special job. And as pediatricians, we always want to be a patient's medical home. And that means having a single provider who knows your child's history and gets to know your family over time and how things are going in your home.
Anna, can you discuss Yarrow's involvement and role in the Nutrition Access Project?
We got brought on by Kate Gerard with WIC to start laying out a framework of how this pilot project could work and how we would be able to track what was working and what wasn't working. What we started with actually was trying to take a bit of a collective impact bend on this pilot project. And so looking at a lot of the different plans and projects that were already in place that were working on this topic, all the way from SDG, Sustainable Development Goals, down to WIC plans and goals that they had set for themselves, and a lot of different grants and state programs in between, state strategic plans, things like that. From that, we created a comprehensive program evaluation plan that includes indicators that come directly from the clinics and from the WIC clinics, and also ones that have to do more with the process of setting a pilot like this up. We also established a change package. I can let Kirsten speak to that a little bit more, as she's more of the QI person and I'm more of the evaluation person. But from that, we've been able to consistently track the progress of the project, come back to the pilot sites and their locations, come back to the larger partners and say, it seems like this is working, it seems like this isn't working, what direction do we want to take? And I have to say, everyone has been very nimble and able to adjust based on what everyone is experiencing, so that the project keeps moving forward in the direction that we want it to.
Kirsten, can you speak through the QI lens, especially elaborating on like the indicators and change package, just terminology that might not be readily understandable?
When you're piloting, you're trying something out, right? There's a lot of trial and error and learning from mistakes, learning from things that went well. And so quality improvement, even as a framework for implementation in this situation, works really well, because we focus a lot on trying small tests of change, what works. So for example, we can take a food insecurity screening tool, try it one time with one physician or one front desk person on one patient and see how it goes. What went well, what didn't go well, and tweak it and try it again. And over time, ramping up for full implementation in ways that really work for that clinic, and learning that whole process, so that the next time as a pilot project, we would like to expand to clinics further. And so when we do that, we'll have a better idea of what works, what doesn't work right out the gate. And we can bypass, we can bypass some of the pitfalls, but also have a lot of best practices available.
Great, that was helpful. I'm wondering, is there like a maybe do you feel like there's one or two of those small changes that happened over the course of time that you think would be worth sharing to this audience? Like, yeah, any and also surprises maybe too.
You know, little things like how do we ask the questions? Like, is it best to do a screener on a piece of paper and have people fill that out in the lobby before they see the physician? Or is food insecurity a kind of topic that, you know, is better done in conversation with the physician or with the nurse? And you can find that out by trying it out in different ways to see what works best, what seems to have the best effect, how do people feel most comfortable answering those questions and sharing their experiences.
There's also a lot to learn about how we're working with each other that I think is really valuable as well. For example, bringing in the lived experts. I think that it might be some of our first times working with lived experts in a more formal sense. And so just being able to learn what that's like together and grow in our own relationships within the project has been really great as well.
Thanks for bringing up the lived experts. Are there like any specifics of that you can elaborate on how engaging with them has maybe shifted your perspective on this collaboration and maybe future projects you work on?
I think they're really, truly invaluable. It's just amazing to have them on any call, because I personally have never used WIC, and I also personally have never worked for WIC. And so to really get this on the ground, true experience of what it's like to walk through the processes, what it's like to need these resources, it just gives such a valuable perspective that I don't think you can really get anywhere else. And that's the point that we're all here, right? That's the point why WIC exists, is to help the people that are using it. And so I just think it's beautiful that they're getting brought in, and it's really like a breath of fresh air every time that we get to work with them.
When we chatted with Kate, she talked about how critical Yarrow is in like tracking everything, making sure everybody can be on the same path together. Can you elaborate on that, either of you?
For tracking, we really look at, from the moment that the patient is maybe engaged in the pediatric setting, every place where they kind of need to be sort of taken to the next step of the process, with the final goal being enrolled in WIC and being able to benefit from those services. So we track everything from, how many well child visits does the pediatrician have? And of those, how many got screened? And of those who were screened and screened positive, how many got educated on the benefits of engaging in programs that can really support them, like WIC? And then of those that are eligible, so possibly eligible for WIC, how many of them actually got a referral? And then we're tracking, of those who were referred to WIC, how many of them actually got enrolled? And being able to track every step of that process really allows us to see where in the process there might be pieces that aren't working, or where we need to work on that system. It's really data driven in that way, but also helps us identify quickly where there can be issues in the system so that we can work specifically on those pieces.
And I would add that on a broader scale, I think that it's been really nice for us to be involved in this project because we helped with the needs assessment. And so we really saw the need through doing the needs assessment of helping with retention and expansion, so that more clients are participating in WIC, and being able to go through that needs assessment. And then now we're just finishing up the nutrition and breastfeeding services plan, which will act like a strategic plan for all of Montana WIC. And then being able to drill down into some of those specific areas with a pilot project like this, really, it gives us the full perspective of how all of these pieces really can tie in together. I just think it's really a testament to how much this is needed, to see that these physicians, even during COVID, even when things are so strapped and so busy, they feel dedicated to taking this on and to making this change and to trying this. It's pretty incredible to see.
Over a year of looking at data from a lot of different sources, talking to stakeholders across WIC, got a lot of information about the program. And one of the things I think that is really most striking is that over 50% of babies and children in our state are eligible for the WIC program, which I think might shock a lot of people. And less than, around 50% of those who are actually eligible actually participate. And so there's a big gap there between who's eligible to participate and who actually is taking advantage of the program. And so there's a lot of room to come up with creative solutions for making WIC more accessible, and getting people in the door.
I also think that we realized, looking at the data, that the people who could be more engaged in the program are maybe not necessarily the people that come to mind. For example, there's wonderful participation happening with tribal communities, really high rates of participation and retention going on there. But there's, I would say, a little bit, well, not a little bit, there is less involvement from people who might be right on the edge of thinking that they're eligible, or knowing if they're eligible, or maybe used to or not used to using services like that, that could really be more actively targeted to be able to benefit from these services. Well, and Kate conceptualized this, and then we started working on it. I think most of us had an idea that this would be fairly simple. It has not turned out that way. I think because it is something that is new, and it's something that has to deal with the processes and bureaucracies that are in place with some of the larger healthcare systems in our state. It hasn't been this quick, easy process that we thought it would be. But that also is a great learning from this. And that's why you do a pilot project, is because you can conceptualize something and then in reality, it turns out to be quite different. And so I think everyone has done really an incredible job in learning and rolling with what is and isn't working to make sure that it can keep going.
So lessons learned so far. Took a little longer than expected. Originally, this is a 1-year plan, and we thought it would, we'd hit the ground running summer of last year. And while we were all enthusiastic and prepared to do that, it did take a lot longer than expected. The systems, including the healthcare systems that the clinics were a part of, as well as the public health entities and others, really needed more engagement and education about the project prior to us kicking off. And then, of course, limited resources. So we moved to the model of referrals. The plan is to evaluate the pilots as they are designed now. We will continue to do that. We just finished year 1 of the project, and we did get funding for year 2. So we will be evaluating the project. We're going to share the results along the way. In fact, we're sharing it here with Great Beginnings, Great Families. We are also sharing it at the Montana Academy of Pediatrics Roundup in the fall. And Dr. Rogers and Kylie Bodley, the executive director of Montana AAP, have been invited to share it at their regional AAP meeting, which is more of a national meeting, which is exciting. And then, of course, we plan to replicate it as much as possible within Montana WIC. We think this next year will be very successful in ensuring that these models are in place and expanded. And hopefully it just means that a lot more families have access to federal nutrition programs that can help them fill in some gaps. Thanks for joining us today. We're all available for questions should you have any.